For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Jemmets Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Pleasant good morning to all of our listeners here on Q100.7 FM. I may sound like an unfamiliar voice now because we weren't here for a couple months, but I'm Shane Seeley, Communications Specialist with the Queen Elizabeth Hospital, as we relaunch the Pulse Radio Show right here on Q100.7 FM. The Pulse is where you can get all of your information about everything happening at our hospital, and we've been busy over the last few months. We have received a mandate under the 2025 to 2028 strategy to get things done to improve service and efficiency at our hospital, and led by our CEO, Mr. Neil Clarke, we've been doing just that, getting some things done, addressing some situations. Everything is progressing fairly well. We can't say that things are set in stone and that we are perfect, by no means, but we're getting things done to improve our delivery of care for our patients right across the board, whether that would be in AED or Accident and Emergency Department, and that's where most of our focus lies today, on our wards, and for many of our outpatients clinics. We're trying to get the job done. So good to be back with you. And as usual, I'm never here alone. I always have specially invited guests like the person I just mentioned, our CEO Neil Clarke. Good morning, Mr. Clarke.
Good morning, Shane, and good morning, Barbados.
It's always good to have you on. And we're also joined by another familiar face, familiar voice, in Dr. Anne-Marie Cruickshank, consultant and head of the Accident and Emergency Department. Good to have you on as well.
Good morning, Shane, and thank you for having me.
And a newcomer to our show and to the hospital, we have now what are called Service Improvement Managers, and we'll tell you in a bit what their role is and how they are helping in that goal and drive to improve efficiency at our hospital and the delivery of care. Dr. Ayja Clarke, great to have you on.
Good morning. Happy to be here.
Yes, and you'll be hearing a lot more from her, because when I'm ready to take vacation, she may be the one to fill the spot and host the show. So I'm putting her on the spot right now and letting everybody listening to us here on Q100.7 know, that she may be that person. But we have a lot to talk about. The CEO has pledged action over a lot of the talking that we would have been doing before. And under the 2025 to 2028 strategy, we've been seeing a lot more of that. Everything cannot happen within a year. We have 3 years to complete a number of tasks. Those were outlined in the last season, and we're going to get into those in a matter of moments. Do you want to start there? Because there was another release that we sent out recently, re our hematology clinic. And we'll speak a bit about that as well. We have Dr. Gill, who will chime in, the Acting Director of Medical Services, about developments there and those patients who have been invited to a meeting tomorrow. But CEO, lead the way. You've been leading us ably for the past 1 year and how many months?
I think we're on 16 months now.
16 months, 1 year, 4 months, if my maths is correct.
So to all of those who said I wouldn't last a year, I'm still here.
Here he is.
We're still going. And it's a 3-year strategy, so I had a bit more time to go as well. So you'll recall that when I joined the hospital last year, it was clear that I could see we've got a lot of dedicated staff, a lot of proud traditions in that hospital, but we also had some deep challenges, long waits, overcrowded in the A&E department, and some weak systems. And we couldn't just patch things up. What we needed was this clear roadmap for change, and that's why we developed with you, the public, and with our staff, the QEH strategy for 2025-2028 to modernise the hospital and deliver that consistent, safe, patient-centred care that we all aspire to do. So our strategy isn't just about fixing problems, it's about becoming the kind of hospital that all the Barbadians can be proud of, and that's patients and staff and everybody in Barbados. We want to make them proud of the Queen Elizabeth Hospital, and one that maybe even the region looks to as a leader in healthcare delivery. So we have an ambitious task, but the first thing is to get the basic steps right. You'll recall when we did the strategy, there was 5 key domains within that strategy. The first one being service delivery, and we're going to touch on that today with the A&E, which is the front door of that work. But the service delivery, its aim is safe, effective, caring, responsive and well-led care. And those key priorities are about reducing waiting times, minimising cancelled operations, introducing clear clinical pathways and protocols, and strengthening patient feedback and satisfaction. We also talked about infrastructure, upgrading and modernising the facilities, upgrading the wards, expanding the operating theatres, bringing in new equipment, and actually I found out just recently an interesting fact. 17,000 pieces of equipment our engineering team look after at the QEH. So a 60-year-old building with the challenges of maintaining that, with 17,000 pieces of equipment. So the engineering team, the infrastructure side, really they're the heartbeat of the hospital that keep the building moving, the electricity, the water, everything else keeping it moving for the rest of the teams. The workforce, the hospital can't work without people. It's the staff who lead the hospital deliveries, and so we've got to focus on how we recruit and retain locally and internationally, how we continually develop our staff, how we move to 24/7 models of care. We have that in some areas, but strangely not in all areas in the hospital. How we recognise staff well-being and staff engagement, so staff feel a real part of the team. Diversity, equity and inclusion for everybody. And also we need to bring in, with nearly 3,000 staff, we need to move from paper-based systems to having a modern HR information system, so we can see who's done the training, we can see who's due the renewals, we can see who's on leave, and we can track these things. Finance and procurement, another of the areas about ensuring sustainability and better use of our money, strengthening financial management and forecasting, improving our cash flow situations, smarter procurement, and we've done a lot of work on procurement recently, and we'll bring that up in a future show. So smarter procurement and inventory management to reduce the stockouts, and regular audits and supplier reviews. And of course, then finally would be ICT and our information management, our digital transformation at QEH. And some of you will recall I said that I want to lead the QEH a paperless hospital, and I arrived there is so much paper, and bit by bit we need to get rid of that. So the real centrepiece of that is our new health information system, and we're expecting to go live with that in September. So we'll start the implementation of becoming a digital hospital in September, and again at a future meeting, a future radio show, we can do a little bit more about the health information system and the IT strategy and all the supporting areas around that, like cyber security, like communications infrastructure, like staff training. Lots of exciting things to happen to enable that. But today we're here, we've got Dr. Cruickshank with us, and we're going to talk about A&E. And this is the front door of the hospital. It's the most visible and the most publicly challenged. Any challenges you'll hear about the hospital, the vast majority will be around the A&E department. And that's because of the number of people that are coming through the A&E department and the challenges that are within there. But let's remind ourselves that an A&E department is one department of a whole system. And it's where the bottlenecks of a whole system will always show up in any healthcare system. If we're not keeping people well in the first place with public health, if we're not doing primary care prevention, we're not doing the screening and the immunisations to keep people healthy, they'll end up coming to the A&E department. If we can do that better, we'll have less people coming in for treatment. And I always say prevention is better than treatment. And at the back of the hospital, we need clear community services so we can move people out of the hospital back into the community once their acute care is finished. But the piece that belongs to the QEH is that flow in the middle, and we're going to talk about that with our Dr. Clarke, who's been doing some of the work on patient flow. But before we do that, I just want to pause and recognise for a moment our A&E team. No other department faces the same pressure as our A&E team. Daily they'll deal with trauma, with sudden death, unfortunately sometimes with gunshots or stabbings, on top of strokes and heart attacks. They'll deal with patients who arrive in pain and in fear, and with family members who may be anxious, angry, and unfortunately sometimes even abusive. It's probably the most challenging place to work in the hospital, and not surprisingly that place gets the most public attention. But often those complaints reflect the stress of the situation and not the lack of compassion of the staff, the doctors, the nurses, the orderlies and the clerks, who the vast majority are doing the very best in an environment that can feel overwhelming. And I'm going to ask Dr. Cruickshank later to speak about her plans for building the team, because whilst Dr. Clarke can speak about the patient flow and improving the systems, a good system's nothing without a good team. So I think probably that leads us on to then, what have we been doing to improve the A&E flow? And maybe then it's a time now to introduce Dr. Clarke, who's no relative of mine. She has a similar surname, although hers is Clarke with the E and I'm the Clarke without the E. Clarke. So Dr. Clarke's been working with our service improvement managers. This is a new team that we introduced earlier on this year, and this team's job is change management experts, internal change management experts. She's been working with some external consultants who've been training and guiding my team and building the capacity within our own team so we can manage change in the hospital going forward, because a lot of change is needed. So Dr. Clarke, do you want to give some of the highlights of what you've been doing with the A&E team and Dr. Cruickshank's team?
Definitely. So when we break down and look at what we've been doing in the accident and emergency department, my colleagues and I, the other service improvement managers, in tandem with the external consultants, we've been looking to decrease the time from the patient getting into the department, so you can get into the department sooner. You can be seen by a healthcare professional sooner. You can initiate treatment sooner. If you need to be admitted or discharged, that can happen more quickly. And then once you get to the ward, we've been working on that end as well to decrease the amount of time that you spend in the ward and get you discharged as quickly and as safely as possible. And we can break that down even further. So when we've been looking at all of these initiatives that we've been doing, we always approach them in the same way. The first thing that we want to look at every time is we want to analyze what is happening, the process, how things are being done currently. We've then engaged the best people, which are the persons that are doing the work every single day. We want to know how it's done, how they do it, who's involved, what are the challenges that they're facing, because these are the persons that are on the ground, so they're the best persons to tell you what needs to be improved upon. And we use all of their feedback and we assist them with generating solutions that actually can work day to day. The next step is actually implementing these solutions and monitoring them. So we can't just say this is what we're going to do to make things better and walk away and leave it. We have to continue. It's a continuous improvement initiative. We always have to go back and look at things again, and we can always add make changes to make things even better. And then once we have an initiative and we know that it's working well, the aim is to standardize the process so it can be done in the best way every time by everyone. So we've been working at different points in the accident emergency emergency department. The first thing we've been looking at is decreasing that time to registration. So once you get through the door of the accident and emergency department, you've been screened by security. What you will see now is you're going to be directed to a digital kiosk, so a self-registration kiosk. So we have different terminals, one at the main entrance for accident and emergency department. We also have one by the ambulance bay as well. And once you get there, you're able to register yourself. In order to make this process as easy and as simple as possible, we have some picture instructions there that will walk you through step by step what you're expected to do. And we know some persons might come on their own, they might come by themselves, so you can either be assisted by a relative, a companion if you have one, or the security officer or the patient relations reps can also assist you with that process as well. So now we have registration time decrease. So once you come into the department, we have registration time sometimes as low as 3 minutes, and as high sometimes at 10 minutes during peak times when things are really, really busy. The next thing we looked at is triage. Triage is that portion where you're seen by the nurse and she determines, how severe your condition is and what time frame you need to be seen within. And we standardize that process as well. The aim was to decrease the time from the person walking through the door and getting eyes on them by a medical professional. So what we've done on that end, we've standardized her work. We've made it, easier for her, to get to those patients as early on as possible. We've also worked with something called advanced triage. So in advanced triage, this is where you can get your investigations done early in the process. And in peak times in accident and emergency now, you will also see a doctor in advanced triage assisting the nurse. And that doctor is there to help to start medications more quickly, start intervention, see the patient and treat the patient more quickly if the condition warrants that, and also order those investigations more quickly, so that later on down the road, you've already had your blood test done, you've already had your imaging done. We've also instituted other interventions, we're looking to institute nurse-initiated medication, where the nurses can also start administering some simple medications on their own, so that, for instance, if you come in severe pain, you can get your pain medication on board as quickly as possible. We're also looking at something called the minor case unit, where simple cases that are less severe can be seen by a senior doctor more quickly, and the idea is for them to be seen and be discharged from the department, so that the more complex cases that need more time, they can also get through the department much more quickly. The other thing we've been working on is patient admissions protocols. So getting that patient admitted to the ward more quickly. So we've looked at standardizing the process of getting that patient up to the ward, finding that patient a bed, and getting that disposition of that patient sorted out. And then on the back end, as Mr. Clarke alluded to, each thing happens in stages, and there are lots of moving parts in the hospital. And up on the wards, we're looking at the estimated date of discharge, and we're utilizing something called estimated date of discharge boards. And these boards really look at making sure there's an easy, accessible way to get all of the information that is necessary and critical to getting this patient home. So everybody involved in the care team, so that's the nurses, the doctors, rehab staff, support staff, everybody can reference this information quite quickly. Another really important part of the estimated discharge board is that patients and relatives now have access to this information as well. So the aim of the estimated date of discharge board is to get the persons off of the ward more quickly and more safely. And we have seen, great response with the estimated date of discharge board so far. Overall in the hospital, I'm happy to report that so far the average length of stay in the hospital is down in all of the wards by 1.2 days. But in the wards that we piloted the boards on, so we tested the boards on, we have noted that the average length of stay is down even further. It's down by 2.9 days in those wards. So we're really happy to see that.
And Dr. Clarke, just to explain, having an estimated date of discharge, how does that make people go home faster? So just for the public, can you explain how having that date keeps everybody focused to get the patient out faster, and how that actually works?
Definitely. So estimated date of discharge, or EDD, is the date that we anticipate based on a patient's condition or diagnosis that they will be able to go home and leave the hospital. It's very important that we listen to the word is an estimate or an anticipated date. It's not set in stone. And remember that we can never use the estimated date of discharge to trump, the doctor's clinical experience. So how much they know about the patient and what's going on with the patient. And remember that we never use it to trump safety. All right, so it's an estimate of when that patient is going to go home. And the idea is that when persons come into the accident and emergency department and they're admitted to the ward, within 24 hours of admission, they're going to have this date set, so that the patient, the relatives, and the entire care team is all working towards the central goal of getting this patient home by X date, within reason. So that means that everybody involved in the care team, so the doctor, the nurse, the therapist, the physical therapist, occupational therapist, the pharmacist, the persons that are responsible for the investigations, everybody knows that all of these moving parts are critical to getting to this patient home, and they can all work together and they know which direction they're going in. So we know that the board has on lots of information, and we know that all of that information is critical to discharge. And if any of those moving parts, if there's any issues with any of those parts, that person's length of stay can be extended. So for instance, if I know that John Doe is supposed to leave the hospital on the 10th, and he's due to have a blood test on the 9th, if that test is not done on the 9th, he might stay a bit longer in the hospital. And then very importantly, I think my most favorite thing about it is that the patients and the relatives also now have this information. Previously, patients might not know a lot about what's going on with them, why they're here, what's keeping them here, when they might go home. And we know that relatives, sometimes persons come to the hospital, they can be quite ill. They might not be, the same as when they came in. They might have a new disability, or they might need new comforts at home. So the relatives can prepare the home and prepare themselves. Even something as simple as having time to get that day off of work, so that they can come and collect their relative, because they know that granny might be going home on X date. Yeah,
all this is very critical information, and I know it helps Dr. Cruickshank in her pursuits to get more patients admitted to the wards, as well as we clear some beds and get more bed space for those who may need to be admitted. And we'll come back to Dr. Cruickshank. We have to take a quick break to thank our sponsors, MedSafe Medical Supplies Limited. They're always standing by us right through all seasons, right here to season 4 of the Pulse Radio Show.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Jemmets Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Here on the Pulse Radio Show, Season 4 starts today right here on Q100.7 FM. I'm here, Shane Seeley, Communications Specialist, with my Chief Executive Officer, Neil Clarke, the Head and Consultant of Accident and Emergency Department, Dr. Anne-Marie Cruickshank, and our Service Improvement Manager, Dr. Ayja Clarke. Before we went to break, I just want to remind you, you can call us. We had to lay the law of the land and let you know all that's happening at the hospital, but you can call and share your concerns, or you may have something that you may want us to know and see how we can help you. You can call us at 434-1007 or 434-1070. You can also send us a WhatsApp. That would go to Kimberly, and she'll send it to me at 434-1007. Thank Kimberly for operating for us today. So we were speaking about those changes and enhancements from AED, the Accident and Emergency Department, that really transcend the department and help us on our wards as well, help our patients, get them the best care possible, and discharge date that they can work with, so that there can be preparation not only in hospital but in the home as well. So Dr. Cruickshank, how have these changes been going? How have you been managing these new things in the accident and emergency department?
I think we've been managing them quite well. We're very grateful to the service improvement managers and the external consultants for working with us for the past 5 months. We've streamlined a lot of the patient flow processes. Just starting with the kiosk, we got rid of that clipboard, and now when we enter the information,
No more paper
at the sign-in kiosk. The clipboard has gone, right? And the family members, patient, and PRRs and the security will help the patient or family member to sign in digitally, and that information is electronically sent to the A&E medical records officer, who now has that available to start writing in the processes and the information for the patient. So that has helped us tremendously.
See.
Then coming into the screening or triage nurse, as Dr. Clarke said, we now have physician-assisted triage. The triage nurse now has a buddy or someone they can resort to for support, where the doctor can assist the triage nurse in terms of assisting with the triage category. Remember, in previous episodes, we talked about the various triage categories in the A&E. So the senior doctor who is working with the nurse assisting can now advise the nurse if this is a category 2 or 3, upgrade, downgrade accordingly, and therefore can now transfer the patient to the appropriate section of the A&E to be seen as soon as possible.
And you have more staff to do this with as well?
Yes, we have our senior doctors working in this area, because you have to have the senior ones to assist with triage.
All right, that is great news. More from you in a minute. Let's go to our first caller. Good morning and welcome to the Pulse Radio Show. How can I help?
Good morning, Mr. Shane Seeley.
Good morning. How are you doing?
I am very concerned about what is happening with the hematology clinic. I am a patient there.
Yes.
And we're not getting any answers.
So you coming to the meeting tomorrow?
I don't think so. I don't know if I'll be able to get there.
You don't know if you'll be able to get there?
No.
What you can do, because I did send a message out in the public domain, and we have been receiving those calls, and we understand you want to know more, and you will hear more here in short order, because our director of medical services, Dr. John Gill, has been working assiduously on getting a solution for patients in the hematology clinic, and I'll share a bit from him shortly so you can listen to that and what will happen for you. But you can also call us at 536-4800 so that you can get some more direction on what will happen for patients in the hematology clinic as well.
Because I'm very concerned, because I mean we need medication.
Yes, you do.
And all that stuff. And there are a lot of old people there that I am concerned about too.
Understood. You definitely should be concerned about your health and your status there and those in the clinic, and we will have some answers for you. I really hope that you would be able to attend that meeting tomorrow, and if by chance you end up doing that, call the number I just shared, 536-4800, so that you can register, and you can also bring your relatives so that they can be brought up to speed on what is happening there.
So in the meantime, and like anyone like take ill or anything like that, what did they do?
Right, so this is the information that you will get tomorrow, Tuesday at 3 in our main auditorium. And as I said, I'll be sharing a clip from our Director of Medical Services, Dr. John Gill, who's been working on a solution to make sure that these patients in the hematology clinic are covered. And I know Mr. Clarke may mention a bit more about that too, but let's hear from Mr. Gill, who has shared what has been happening, what would have happened, which would have caused this pause in the clinic, and what is the solution, what we are looking for as far as the solution is concerned in the interim, both short, medium, and eventually long term.
On the 2nd of July, the clinical services rendered by the hematology clinic at the Queen Elizabeth Hospital suffered an unexpected interruption due to the sudden unavailability of the sole consultant hematologist on staff at that time. This created a huge challenge to quickly source at least one consultant hematologist to maintain the continuity of care for all patients who require clinical hematological expertise. Efforts were made to secure consultant leadership for that clinic and the hematology service in general on a short-term basis to prevent treatment delays of any patient who needed to be seen by a hematologist, and to recruit 3 consultant hematologists to secure the long-term viability of the hematological clinical services at the Queen Elizabeth Hospital. 2 hematologists in private practice were asked about the possibility of part-time consultation. One doctor said that their practice would not be able to accommodate their absence. The other stated that they would be able to commence in early August, initially on August the 5th, and then on the 9th of August, if certain conditions of service were met. It was a surprise on the 9th of August when I was informed that the date of commencement was then moved to the end of August, leaving a very difficult void to fill. Short-term consultant expertise had to be sourced from elsewhere and is currently being sourced beyond the shores of Barbados. Currently, communication with Barbadian hematologist-oncologist who is in the practice in the United States of America. She can convene a hematology clinic and provide patient consultation by real-time video conferencing with the aid of a dedicated clinical assistant. However, she's unable to start before the end of August. I would say almost simultaneously, negotiations are ongoing with the Pan-Caribbean healthcare entity for 1 or 2 of their hematology-oncology consultant providers to assist by consulting in person at the hematology clinic. 3 doctors were interviewed during the 2nd and 3rd weeks of July for consultant positions in hematology. As far as I'm aware, all 3 of them were offered the opportunity to join the staff of the Queen Elizabeth Hospital as consultant hematologists on a full-time basis. They are all working in hospitals abroad and cannot be here before October. We're hopeful that at least one of them can start in the month of September, and we're negotiating with them to see which one can arrive here as soon as mid-September.
That is Dr. John Gill. He is the Director of Medical Services, acting also our neurosurgeon at the Queen Elizabeth Hospital. CEO, anything that you would like to add to that? Because I know that there have been questions about the service and what we're doing for patients in the interim.
Yeah, sure. So I want the patients to be really clear that the team's working non-stop trying to resolve this issue. And as Dr. Gill said, the issue arose because we lost a consultant with no notice. So I had no notice, and immediately then we had to try and find replacements. We reached out to the local clinicians and said, can they come and work within the hospital? And we had some dates provided, but then for one reason or another they were unable to start with us. We reached out to local consultants, said, can we outsource our patients to you? But they said that they had no capacity. And then we've reached out internationally, regionally initially, to say we need some support with this, because as the patients are saying, rightfully so, they're very worried about the lack of treatment. I'm hoping, and it's just unfortunate because I was meeting this weekend and I was hoping we'd have a start date, so we've identified a number of haematologists who are going to come and join us, but they're coming from overseas and we have to just quickly sort out all the paperwork to get them here. And I was hoping that by today we would have had that information, and I'm hoping and I'm sure that by tomorrow we should have more information on that, and that's the aim of the meeting tomorrow, to go through with the teams what we're doing, where we're up to, and what we can do to support you in the meantime. So I 100% understand the concerns. I've spent a couple of hours, I would say, speaking to different patients about their concerns, and I want to assure everybody that we're doing absolutely everything we can to resolve this as soon as we can, and we're hoping that tomorrow at the meeting we'll have further information on how that's been resolved with the overseas temporary recruitment. And I think, as Dr. Gill said, we have a number of posts. Those posts have been interviewed, appointments have been made, onboarding has started. So the long-term solution, the meeting in the next month or so, is very secure. It's just this interim arrangement, but we're fortunate that we've identified somebody who can provide that support for us, I just need the confirmation of that start date.
Yes, and that's what you will hear tomorrow at the meeting. Remember, that meeting is at 3 p.m. in our main auditorium at the QEH for patients, and we are asking you to call 536-4800 to indicate your attendance, and if indeed you want to bring a relative, you can do so, and you indicate who will be attending with you, so that we can meet with you and explain to you what is happening with the hematology clinic. Also, you can call the PBX at 436-6450, and you can ask to be transferred to the Office of the Director of Medical Services. If you want to follow up and get any additional information in the interim, you can do that by calling the PBX at 436-6450. Ask to be transferred to the Office of the Director of Medical Services for further information as well. And you can do that by calling the Patient Advice and Liaison Service as well at 536-4800. I think also some patients may have been going to the AED to seek services, and Dr. Cruickshank can speak a little bit more about that. But Dr. Cruickshank, you were speaking about this transition, this digital transition, which is a big benefit for the patients coming to AED, which these other patients would also been benefiting from when they came to sign in and go through triage.
Yes, so as they enter digitally into the system, that information goes directly to the medical records officer. So they already have the information to start processing the front sheet. From there, they would then go to the, as we said, the screening or triage nurse. We have physician-assisted triage, and we can now start the investigations, the pain meds, the imagings being ordered. Everything can start from screening or triage. So by the time the patient gets to the doctor, that those things are already in the system, and results may already be back, so that we can start seeing them straight off with the information already obtained.
Good. And I mean, when you see the response or the feedback, I mean, you can gauge it by just, seeing how people respond when using these new systems. What are you seeing? Are people a bit more encouraged that we're going in this direction in terms of at least streamlining that process?
Definitely. First of all, the staff, I mean, the triage nurse is very happy with the additional presence of the senior doctor assisting. So off the bat, the patients are happy too, because they're getting things done, and when they see things happening, they feel as if we're getting to the doctor soon, and they feel comfortable. Their pain may be relieved, they're getting imaging done, they're getting their investigations and bloods taken off, so they feel as if something is happening to get them closer to their diagnosis, treatment, and then disposition.
And does this help you to not miss any of the patients who are signed in or are waiting for treatment?
Correct, because on a clipboard, if they forgot to sign in or what have you, or they may not hear their name when their name is called, whereas electronically, that information is sent directly to the medical records officer, so she can then call the name that is presented to her monitor and start processing the patient.
This is definitely good news. 434-1007 or 434-1070 is the number to call us here on the Pulse Radio Show. You can also send us a WhatsApp at 434-1007. And when I hear about these changes in A&E, because coming into the hospital, everyone always spoke about waiting times, and I think that is really the center of why we're trying to create a more efficient system. Will this overall help to reduce waiting times in the A&E? And I think that's a question that most Barbadians would want answered. When I come to the A&E, do all of these processes help to decrease how long I have to wait there? And both of you can jump in on this.
And I think if I can just jump in there first, I think the answer is yes. And what it is they break it down. There's a journey through the A&E department, and each piece of that journey we're looking at how can we improve this part of the journey, and the first part was the reception, arriving. How can we improve the triage? How can we improve the time to see a doctor? How can we improve the time to get pathology or diagnostic tests back to the doctor? How can we improve the time for the doctor to get a specialist opinion? How can we improve the time to get the patient admitted to a bed, which then led to the second journey that the service improvement manager were doing? How can we manage the flow through the inpatient beds so the beds become available more quickly? So each part is broken down, and I always says you can't eat an elephant in one go. You have to take him piece by piece.
That's a new one.
And that's what they've been doing, and they've broken down all those different steps, and they've been working on all those different steps, and this work is ongoing. So this isn't something where we press a button and tomorrow it all changes. This is something where we press a button and we've got to keep our finger on that button for quite some time while we create new habits and new practices with those teams in there. So I don't know whether you can say at this time, Dr. Cruickshank, how much of an improvement we're seeing on waiting times flowing through the A&E department.
I think Dr. Clarke is the one doing the measurements.
So I can actually speak to that. As I said, we get great feedback from the staff, we get great engagement from them, they give us recommendations and we come up with solutions, and then we monitor to see how they're working and we make changes as we go along. And I can happily say that since introducing the changes, especially with the introduction of the physician assisted triage, that the wait times between patient coming through the door and getting to triage are down by 40%.
That's great news.
With the introduction of those changes. And as the CEO rightfully said, we look to see, what were the challenges, and we've taken out the challenges and we've tried to address each one, a small bit at a time. And one of the important things which I didn't mention earlier we've been working on is also getting the investigations done, getting the results back more quickly. So now we have somebody the orderlies are now taking the samples to the lab every 15 minutes. Emergent samples are still being taken immediately, but we have standards that every 15 minutes blood samples are being taken to the lab to be tested. And we've also standardized the process for getting the investigations, like the imaging and the x-rays and the CTs ordered, so that can be done more quickly. The quicker it's done, the more quickly we can get back the result. And we know that a lot of times persons can spend time waiting in A&E, waiting for those results, to be admitted to be seen by a specialist. So now we're getting those done more quickly. We expect those wait times to continue to go down as well.
So much going on there, isn't there? And I came down to meet with Dr. Cruickshank, and even things like procurement and supplies, making sure that the doctors and the nurses have the supplies that they need, and you've been doing lots of work in that area as well.
Yeah, so the external consultants worked with us in our main storage room and our step-down storage room. So we now have a particular system where the step-down storage, we get supplies from the main storage to the different satellite areas in the A&E, and it is very important that all these satellite areas are well stocked. And we're doing pretty well at the moment. We may just have maybe one or two things that are in limited quantities, but I think we're doing pretty well in terms of having the areas stocked. And then we replenish the main from the step-down storage room, and the external consultants have implemented a system where we are triggered or to restock. And it's been working pretty well, and we're quite pleased with our A&E procurement system.
I like when I hear you say those words, that things are working well and you're pretty pleased, because I know it's genuine. So that means we're definitely moving in the right direction. And speaking about moving in a direction, let's again thank our sponsors, MedSafe Medical Supplies Limited, and we will welcome some more phone calls from you, and we know you're waiting on the lines. We'll answer those questions that you have. The Pulse Radio Show brought to you compliments MedSafe Medical Supplies.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Jemmets Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Back with you on the Pulse Radio Show here on Q100.7 FM, the place that you can find your friends from the Queen Elizabeth Hospital to answer the many questions that you may have about navigating the system. I think we have a call on the line. Okay, that call dropped off. And we were speaking about making sure that we are a bit more efficient and we are a bit more quick in dealing with patients right through the hospital system, but we also must show a bit more empathy as well. And Dr. Cruickshank has been really leading the charge to, have her staff, be a bit more compassionate. I mean, it's an active area. It's an area where all the action is at the hospital. When I say action, in terms of people coming through the doors of the hospital with their concerns, medical concerns and complaints, and people may be afraid. People may be worried. So we have to show that compassion in terms of the care that we offer to these patients. How do we best do that? Especially in a place where we're seeing gunshot victims, we're seeing stabbing victims, trauma victims from accidents, people coming in with heart attacks, people coming in with complications from non-communicable diseases, Dr. Cruickshank. This is your everyday reality.
Yes, it is, Shane, and you have to be able to manage these situations. The staff has to be able to manage them and manage them professionally. And as a result of that, in addition to the processes that we're streamlining, we now have to work on the staff on attitudes and behaviors and work on their empathy. So we're engaging in a team leadership program. We're hiring an HR consultant to work with us, hoping to start from September after the external consultants leave. We're bringing in now the HR consultant to work on the attitudes, behavior, the empathy, and to make us better team members and team leaders, because they're working on the management team also. Because if the head is bad, the body going to be bad too. So we have to work on the head. The management team of the A&E will also get training, and also the staff will get training. So this is probably going to be maybe a 6-month program. So hopefully by 2026 we'll be looking in a much better position in the A&E.
And this is very important for you. I can see the emphasis. Why is this so critical for the success of the new A&E which you now lead?
It is important to me because we need to revise the image of the A&E. And I feel personal about this. I've been in A&E for 33 years. And I want to display the best we can offer to the Barbadian public. So not only processes, but attitudes and behaviors have to be worked on.
And let me just throw something in there too, Shane. We know that Dr. Cruickshank's team get it right the vast majority of times because we do patient surveys.
Yes.
And those patient surveys say that less than 5% of the people were unhappy with the service. Now, any statistic that we put out there is meaningless, because if you're one of those 3 or 4% we didn't get it right for, you don't care about the rest of the statistics. And I understand that completely. And we want to eradicate it, that every single person gets the best service possible. But we need to keep it into context that over 95% of our patients are happy with the service that they receive, and only a small proportion are not. But what we need to do is you need to make sure that when somebody's not happy with the service that they received, that they tell us, Shane. And I always say, if we don't know we got it wrong, it's very hard for us to put it right. If we don't know who got it wrong, or where we got it wrong, or what we got wrong, it's really important. So I know, Shane, that you always lead in with this, is to we need to hear the stories from the public about when we got it wrong. And of course we still always welcome the stories from the public about when a member of staff went over and beyond for you, because I do get those letters in quite often of when somebody's gone over and beyond, and we acknowledge those at our staff award ceremonies.
Indeed.
So Shane, just remind everybody what to do if they've had a bad experience, how to communicate that.
Well, there are a couple ways that I encourage people to use to connect with us, and they can always go through www.qhconnect.com. On that page they can scroll right to the bottom, and they will see what I'm seeing here now, your feedback matters, and you click that link and you have an electronic way to do that. I know for some people we deal with a number of people from the elder population, those senior citizens, so I always encourage them to call us, and they can call the PBX. That's the easiest or the easier number to remember, because we have a lot of extensions in the hospital. So just call the PBX 436-6450, and you can ask to be transferred to either the patient relations department. You can call that other number that I'll give in a minute, but stick on the 436-6450 for now. You ask to be transferred to clinical risk, and there you will hear one of our representatives who is there willing to take that complaint you can follow up with them as well, but they will take that complaint from you, and then they will investigate and get to the bottom of that story, get to the bottom of that situation. So that's the best way to do it in terms of calling and connecting. Remember the website, you have that number 436-6450 that you can ask to be connected to clinical risk. You can also walk in to the doors of the Queen Elizabeth Hospital, come through the main entrance, and it's a short right turn, and on the left hand side you'll see a door and you'll see clinical risk department and clinical risk manager, and you go there and you can also dictate your complaint to our clinical risk team. They're very willing to help you. They'll help you articulate what your complaint is, and then we can definitely follow up. I know many of those issues even end up on the desk of the chief executive officer, and he handles some personally. So it's a process that we want people to get accustomed to, because if you complain on, to say for instance, we've seen some complaints coming out on social media, we see some end up in the newspaper as well, on radio stations. We don't get those directly. It is better if we get them directly through our clinical risk department, through our patient relations department. And remember, you can call the number that I always talk about, 536-4800. That's our patient advice and liaison service. You follow any of those modes of interaction that I just explained, and you will have a direct response from us so that we can better handle your complaint, concern. And even in those cases that we do get those many compliments, we can share them with the public, because we do get many compliments as well for the service rendered by our medical teams.
And we've been doing a lot of work too on quality, which includes collecting information from patients and from staff, near misses when we nearly got it wrong, but we caught it early, and when things go wrong. And I think at a future radio show we'll be having our Chief Operating Officer, Dr. Christine Greenidge, here, and the quality team explaining how they use this information to prevent further occurrences of the challenges. And that's why it's really important that we capture the information, because we do use it and we put it into our governance system to identify patterns and trends, and then respond to those patterns and trends with actions to eliminate further occurrences. So please, I always say, please do share your bad experiences, and also of course please share your good experiences.
Yeah, and you speak to the future occurrences, but we try to help you so that we can avoid things escalating or going wrong for you even further, because the faster we know that something is wrong with you, the faster that we can help you correct the situation and get you on that path to better health. No one wants to see anyone's health deteriorate or go in the wrong direction. We're here to help you go in that right direction. So when you issue us those complaints, we can investigate, yes, to help others who may have similar complaints, but we can better help you. So instead of calling the radio station, or instead, I'm not stopping you, you're a free person, that's your right to do that. But if you want that help for yourself, call us so that we can better help you. And in the instance that you think it's taking too long, don't be afraid to call back, or get another, you can go a step higher. Go to the CEO's office and said you call. Sorry, CEO. say you called and you were not getting the response you need. And I'm very sure that he will, if he doesn't help personally, he will direct you where you can get that help.
Absolutely. So as the show's running towards an end, I just wanted to pick up. You just heard today of a lot of changes that are happening on in the A&E department, and then the flow through the inpatient beds. There's so many changes happening, and maybe we could try and get something onto the website or circulate out showing you did the mapping of the whole system. I think we should share that with the public, and just they can see.
We'll do one better.
This is all work in progress. This is all work in progress. But we really wanted to show the public that we wrote a strategy, and now we're implementing it. So we said we would do it, and now we're actually doing it. And over the next few weeks and 2 months, I think we've got the show going on for.
Yeah,
we're going to be coming back with all the different executive directors saying what have they been doing, what's their contribution towards the implementation of the QEH strategy.
Yeah, I just want Dr. Cruickshank to pick up on this WhatsApp that we've received. Given a fake story about the AED that was on social media this weekend, can the panel say what are the procedures on arrival. So I don't know the fake story because that one missed me, and probably someone would share it with me and we could further discuss it next time around. But just to make it clear for, of course, our patients and the general public, the procedure on arrival now with our new digital system.
Well, as Dr. Clarke noted, you have to go through security. You must go through the security checkpoint, either at the main drop-off area or through the ambulance bay. There are 2 security checkpoints, and that's to ensure that no harmful weapons are entering into the A&E. From there, you're going to go to the digital sign-in kiosk, both at the front and at the ambulance bay, and there are about 5 questions which are simple for you to fill in for the registration process. If you need assistance, we can provide that for you. From there, you will go into medical records, any medical records for the front sheet to be filled out, and then you go to screening or triage, where you will meet both the screening or triage nurse and the senior doctor who is assisting the triage nurse to start the process. And you will get your initial treatment, and you can either go straight into a treatment room, go into the resuscitation room, or you just will wait until they're ready for you to come in to see the doctor. If it's a minor case, you'll go straight into the minor case unit with another senior doctor seeing you to get you sorted as quickly as possible. So that's the initial arrival process.
Yeah, so hopefully that clears up any misconceptions that have been put out there. Hopefully I get an opportunity to see what this fake story was so that we can properly address it and ensure that people have the right information. And that's why we're back with you here on the Pulse Radio Show, so that you have all of the correct procedures and information coming from the mouths of those who are operating in many departments at the Queen Elizabeth Hospital. As the CEO just said, we'll have a number of our experts on this season, our directors especially, across departments, to let you know what are the actions being taken to improve efficiency across the board. So we'll be sharing a lot more with you every Monday at 11 a.m. here on the Pulse Radio Show. Let's talk about some final comments from each of you, starting with you, Dr. Clarke. When we look at the entire improvement process, and you as a service improvement manager, a new role in the organization, where do you see departments like our front-facing AED going within the next 6 to 12 months?
Based on the level of engagement that we've gotten from the staff so far, I can only see things improving further. I think the introduction of a service improvement manager is a real testament to the hospital's attempt to address the strategic goals and initiatives that they have and heading in the right direction. And I just want to emphasize that every initiative that we undertake is always with the patient at the center of it, where we really want to emphasize a patient-centered approach. And each thing we've talked about this morning is really about getting the patient, improving the quality of care we delivering to the patient, making sure it's consistent, and the patient is always at the forefront of our mind. So I just wanted to end on that.
Final thoughts, Dr. Cruickshank?
I think it is a wonderful initiative. I thoroughly enjoy working with Dr. Clarke and the other service improvement managers. They have helped us tremendously in the A&E over the past 5 months, and I look forward to working with them again. It has helped my job tremendously.
When you said Dr. Clarke, I got a bit confused for a minute because I know sometimes Mr. Clarke, they always call you Dr. Clarke.
Dr. Clarke, yes, it's Mr. Clarke. So from my perspective, we brought the service improvement managers in earlier on this year, and it was something I realised we needed when I was here last year, and I could see that the departments were working very busy managing the day-to-day operations, and they didn't have the space to think, how do I make a change? Right. Now, the service improvement managers can't make a change, but they can bring the tools and find that breathing space for the departments to enable that change to happen. They've been focused on A&E pathway and what I call the unplanned care pathway, A&E, inpatient flow and discharge planning, and we'll move them at some point in the future to the planned care pathway. So those of you who are waiting too long for your outpatient appointment, or it's being cancelled, or your theatres and it's being cancelled and the waiting times, we'll move them onto the planned care pathway. We'll move them onto the diagnostic pathways to make sure the diagnostic tests are done quickly, and also to the cancer pathways. But what I sense already and what I feel when I walk around is I feel there's a change coming. I feel that change in people who are speaking to me and talking to me. I feel people are getting permission to do things. And it feels that it was always they were waiting for the CEO to say, yes, you can do this. And I keep saying it's your department. If you think that works better, try it. And that's happening. Already the Service Improvement Manager has been working on the cancer pathways, and I just want to finish the show off on another good news story. You know, you would have seen the cancer waiting times at 140 days for your first outpatient appointment. We're now down to 3 weeks. We're down to 21 days from 140 days. And again, that's that team in the oncology department just taking the initiative and saying, okay, we're going to fix this, we're going to improve this for the population. And the more we see that happening in the different teams across the QEH, the better for everybody.
Definitely. And it's a good way to end this edition of the Pulse Radio Show. Remember, we're back next Monday at 11 a.m. But before we get to that, remember, patients in the hematology clinic, you've been invited to a meeting. That is tomorrow at 3 p.m. in the QEH main auditorium. You come to the front entrance, security will guide you there. But before you get there, please call 536-4800 to register your attendance, and you can bring a relative or someone that is connected to you that helps you with your care. That's it for this edition of the Pulse Radio Show. On behalf of our CEO Neil Clarke, Dr. Anne-Marie Cruickshank, our Head of Accident and Emergency, and Dr. Ayja Clarke, she is our Service Improvement Manager. We thank you for listening, and tune in next week for the next edition of the Pulse Radio Show, where we get more about the strategy in action 2025 to 2028, what's happening over the next 3 years at your hospital.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.